From simulation to competency. Validation of a low-cost ex vivo model for bilioenteric reconstruction. Every successful hepaticojejunostomy begins long before the operating room. It begins with structured training. Bilioenteric reconstruction remains one of the most technically demanding procedures in minimally invasive hepatopancreatobiliary surgery. The small diameter of the bile duct, fragile tissues, and the need for precise intracorporeal suturing create a long and challenging learning curve. Despite these challenges, access to realistic simulation remains limited, particularly in low-resource settings. To address this challenge, we developed and validated a low-cost ex vivo simulation model capable of reproducing the essential steps of laparoscopic bilioenteric reconstruction using readily available biological tissues. The model was designed to provide standardized, reproducible, and competency-based surgical training before clinical application. Bovine intestine simulates the jejunum, while chicken trachea or esophagus reproduces the biliary duct. The intestinal enterotomy and biliary opening are created under laparoscopic visualization to ensure proper alignment prior to a reconstruction. The posterior wall is constructed using interrupted sutures with equal spacing to achieve precise mucosal approximation while minimizing tissue tension. Suturing begins at the inferior edge of the intestinal opening, facilitating controlled mobilization of the jejunum toward the bile duct and reducing the risk of biliary tearing. The needle passes from outside to inside through the intestine and from inside to outside through the bile duct, leaving all knots in an extraluminal position to minimize the potential for postoperative stenosis. Although these differences from conventional in vivo techniques, this modification improves technical feasibility in a laparoscopic training setting while maintaining anastomotic integrity. A 10 French Nelaton catheter may be inserted as a temporary intraluminal stent to maintain patency during completion of the anterior wall. This step remains optional within our simulation protocol. The anterior wall is completed using a continuous full-thickness suture while maintaining uniform tension throughout the anastomosis. The same needle orientation is preserved, beginning inferiorly and progressing superiorly to avoid excessive traction on the biliary tissue. The completed anastomosis is calibrated to verify the final luminal diameter, confirming an approximate caliper of 10 mm. Finally, a hydropneumatic leak test by instilling saline or water under pressure confirms adequate patency and watertight reconstruction. Validation of the model. To objectively evaluate the educational value of the simulator, 50 consecutive laparoscopic bilioenteric anastomoses were performed following a standardized training protocol. Progressive improvement in operative performance was observed throughout the series, with a continuous reduction in operative time as technical experience increased. Cumulative QSUM analysis objectively demonstrated acquisition of technical competency after the 19th procedure, identifying the transition from learning phase to procedural proficiency. Published learning curves for laparoscopic bilioenteric reconstruction often require about 50 to 100 clinical cases to achieve competency. In our validated simulation model, objective proficiency was reached after only 19 simulated procedures. Overall, the model achieved a mean operative time of 33 minutes, a mean anastomotic diameter of 11.4 mm, and successful leak-free reconstruction in 90% of cases. All observed leaks resulted from identifiable technical errors, providing immediate educational feedback within a safe training environment. Beyond standard hepaticojejunostomy simulation, the model also reproduced advanced reconstructive scenarios including double duct biliary reconstruction, allowing progressive exposure to increasingly complex hepatobiliary procedures without patient risk. Simulation is no longer an adjunct to surgical education. It is an essential step toward technical excellence. This validated low-cost ex vivo model provides an accessible, reproducible, and competency-based pathway for mastering laparoscopic bilioenteric reconstruction. By shortening the learning curve before a clinical application, it has the potential to improve surgical proficiency, enhance the patient safety, and expand access to advanced hepatopancreatobiliary training worldwide.